Our next speaker is Dr. Christine Sinsky, who is already known to many of you. We have been friends and colleagues, I think, going back to a REN meeting that must have been nigh unto 12 or 14 years ago, where we first met each other. And I was always very impressed by what she had to add to the dialogue, and even more impressed now that she is leading an absolute groundswell of enthusiasm for making primary care doable, for decreasing the burnout for everybody. And I appreciated the comment that I get concerned about too, that we oftentimes can unload or offload tasks to other team members who may be every bit as much at risk for burnout as those of us who are doing the front line work are. So, Chris, take it away.
Thank you, John. It's great to be back here, and if you bear with me for a moment, I will bring up the slides. And I'm going to unhide one slide just based on Tom Bodenheimer's talk, if I can make that come up. So, okay, let's make it move. Unhide that one. Okay, let's go to the beginning. Sorry for the pause here. I obviously can't do this one-handed, and I think it's backwards from the way I'm used to doing mine. I guess we do.
Is there an engineer in the house?
Okay, so, right. In any case, thank you for inviting me back. It's my pleasure to come back. What a beautiful setting. Tom and I went for a walk along Lakeshore Path this morning, so it's already been a great day. And so what I'd like to do is kind of give you an update about where we are with some Joy in Practice work. And we'll be talking primarily about a study that we did at the AMA on time allocation of physician resources. And then I'll discuss 3 other time studies that have come out and a few other key studies, and then we'll have time for discussion. But I'd like to start by a quote from, this is Dr. John Noseworthy, who is the CEO of Mayo Clinic. And last September, we brought together 10 CEOs from among the largest organizations in the country. And they recently published a blog on health affairs, and it was a call to action to their CEO colleagues. And one of the statements is that physician burnout is a public health crisis. And as Tom said, physician burnout now affects over half of U.S. physicians. And as I've shown before, that burnout rate has increased dramatically in just the last 3 years. And it is double the burnout rate in the general population. And a couple of years ago when I was here, I introduced you to my niece, Alex. And Alex at that time was an intern. She is now just graduated from her primary care internal medicine residency at UCSF and is looking for her first position. And she called me and said, "Aunt Chris, what should I look for in my first job?" And that caused me to wonder where she will be in a couple of years and where she will land. And will she land in an organization where this is the model of the patient-physician relationship? This came from Annals of Internal Medicine, this painting. So will she end up there where we know we are doing the wrong work for our patients, and that disconnect between our mission and the work we do is what's driving burnout? And that might be exemplified by this physician's note. "I am no longer a physician, but the data manager, data entry clerk, and steno girl. I am frustrated, unhappy, and I'm unable to do my best in caring for our patients. I became a doctor to take care of patients. I have become the typist." I don't want Allie to end up in that situation, but I think the odds are, for a primary care physician, that's the more likely scenario, unless she's very careful at what she chooses. And what I hope for her is that she's able to find a place like Bellin Health, where she can be giving her full and undivided attention to the patient in this very advanced team-based model of care. And Jim Jerzak then describes what's happened in his life. The team support has made practicing medicine fun again and much more fulfilling. And I also want to put forth a challenge that I've put forth here before, and that is I think most primary care physicians and teams can save 3 to 5 hours a day by re-engineering the way we do our work through a whole number of individual efforts at pre-visit planning, at prescription management, at expanded rooming and discharge protocols for our staff, and through team documentation. So with that as background, I wanted to talk about what's new. And so we'll talk about several studies. The first one is the study that was published in Annals of Internal Medicine at the end of last year. And it's a study that we did in conjunction with Dartmouth. And did I skip over? Did something? Okay, no. So and the central question that we asked was how is physician time allocated throughout the day? And we were interested in how time was allocated both during the clinic day, in the exam room, and then after hours. And we looked at this and we categorized the work. We rolled up all the different task categories into 2. One was direct face time with patients, and the other was EHR and desk work. And the study was of 57 physicians and across 4 different specialties: internal medicine, family medicine, cardiology, and orthopedics. And the practices came from 4 different states across the US. And we trained 10 medical students. These medical students were from several medical schools. And we trained them in direct observation. And then their ability was, we had some inter-rater reliability testing that we did based on some standard video scenarios. And they went in pairs to the different sites, and they spent 2 hours observing and then 2 hours interviewing. So they switched on and off so they wouldn't get observer fatigue. We had a tool called the Wombat tool that came out of Australia that was used. But you could imagine it somewhat like an iPad app. And there were the different task categories and who they were observing and what they were doing and with whom and where they interrupted. So that was the basic data collection tool. And the results that we got then were that during the clinic day, fully 50% of the physician's time was spent on EHR and desk work. And less than a third of the day was on direct clinical face time with patients. And I think that's a really important piece to look at. Only a third of the time was on direct face time with patients. So when we're thinking about Tom's question about how do we get demand and capacity to match, we have a tremendous amount of waste. Now, not all of that half the day that's on the EHR and desk work is waste, but I can bet a big chunk of that is. So said another way, for every 1 hour of direct clinical face time with patients, physicians spent nearly 2 additional hours on EHR and desk work. Now, despite that, well, excuse me, before we get to that. So that was of the day. Now let's just look at that portion of the time that the physician is actually in the exam room with the patient. Now, even there, physicians were only able to spend just a little over half of that time in the exam room giving direct, undivided attention to the patient. And over a third of the time was spent on EHR and desk work, that business of this or not even. But despite spending half the day on EHR and desk work during the clinic day, physicians were routinely taking 1 to 2 hours of work home at night to be done on their personal time. The other thing that we found, although this is something that I think needs more exploration because our study wasn't powered to determine this, but there was certainly a trend that those practices that had more documentation support, either with the ability to dictate or with a clinical assistant who assisted with documentation, spent more time in direct face time with their patients. So it was all primary care that didn't have documentation support. Only 23% of the total day was spent on direct clinical face time. But as documentation support increased, so did the amount of direct face time that physicians were able to provide for their patients, which only makes sense. Okay, so in summary, what we found in this study was that 50% of the day was spent on EHR and desk work. There was 1 hour of face-to-face time for every 2 hours of EHR and desk work. And there was 1 to 2 hours of work taken home at night, what's been called pajama time. So this study, I think it was published online in, I forget, maybe November or December. And to my surprise, just a couple of months later, also in Annals of Internal Medicine, was published this study. It was completely unrelated to the study that we had done, came out of Switzerland, and had almost the identical title, allocation of resident time rather than physician time. And what they were doing was looking at residents at the hospital in Switzerland. And they found 50% of the day was spent on the computer. Less than a third of the day was spent on direct patient care. And for every 1 hour of direct patient care, these residents were spending 3 hours on the computer. And despite that, they were taking 1 to 2 hours of documentation work to be done after their shift was over. So the categorizations were defined slightly differently, but the overall picture is looking fairly similar. And then this is a study that was just published in Health Affairs just within the last month. And this was a study using EHR audit data. And with this, they were able to look back at the care that almost 500 physicians had given to about 800,000 patients. And they found that 40% of the time was in the office visit itself. About 40% of the time was doing what they called desktop medicine, refills, documentation, inbox work, and 20% was other. So again, their categorization was slightly different than what we used in the study that I first presented, but it's painting the same picture. A pretty big chunk of the day is given over to documentation. The other really interesting thing here was that the time spent seeing patients decreased from 2001 to 2014. Now, those happen to be the very same years that we did the burnout data, where we also saw burnout going up. And of course, they're different studies, but they're, I think, pointing to the same phenomena. This is a little bit of a nuance about their data, but they had split up the day between face-to-face visits and desktop medicine. But if you look deeply into their data, almost half the time that the physician was in the room, a face-to-face visit, was spent doing EHR kinds of work in the room. So a couple of other studies that I want to highlight for you. This is a study that we did with the Mayo Clinic looking at the nature of the electronic environment and the clerical burden of the environment and burnout. And the takeaway message here was that physicians who were in an environment where CPOE was a requirement had 30% higher rates of burnout. So that the EHR is a source of burden for physicians, but it appears that the CPOE element of the EHR has been the most burdensome. And as Phil and I were talking ahead of time, I think many physician organizations do not know that as of January 1st, all federal requirements for physician order entry have been removed. And so any requirement that order entry be performed by a physician is an institutional level requirement, but it is no longer grounded in any federal requirement for that. Well, burnout is costly to organizations. And previously, when I've been here, I've shared that a study back in 1999 showed that it cost $250,000 to replace one primary care physician. When we brought together the CEOs from a variety of organizations last fall, one of the CEOs said, well, at our organization, it costs $1 million to replace a physician. So I was curious about that, and then saw this report that came from a recruiting firm. And in this report, it's estimated that depending on the length of the vacancy, it actually costs $800,000 to $1.4 million to replace a physician. And that's when you consider the lost productivity in the closing down period and the ramping up period for that vacancy. I think we could make the case that the cost is probably even greater when we think about the disruption of continuity and we think about the reputational risk that an organization has when it has a high turnover rate among their physicians. This is a study, a data point that comes from Tate Schoenfeld, that if there's a 1-point increase in burnout on a 6-point scale, that predicts a 43% increased likelihood that the physician is going to cut back on clinical effort to that syndrome that Tom referred to of the part-time syndrome. And if we look then and take that data and we overlay that, if you will, with the increase in burnout from 2011 to 2014, that's the equivalent of losing 1,000 physicians, the capacity of 1,000 physicians in the country, just from the number of physicians who have coped with burnout, with the increase in burnout by cutting back to part-time. Well, that's the equivalent of 7 medical school classes, the graduating classes of 7 medical schools. So in a sense, we have this option. We can either train more physicians or we can lose fewer physicians. Now, I was looking at this data, and it's hard to find data on what it costs to establish a new medical school. But the best evidence that I can come up with, and I've spoken with some people who are starting the new medical school at Dell, for example, in Austin, and someone who's done a study through AAMC of new medical schools. So my best estimate is probably around $100 million to set up a new medical school. And we've set up, I believe, recently there were 12 new medical schools that have been established. So we can either train more or we can lose less. This is a study that I'm just finishing writing up and ready to submit for publication, so you get to hear it hot off the press. This too is AMA and Mayo Clinic working together. And it's looking at the career plans of U.S. physicians. And what we found was that about 2% of physicians have said it is likely or definite that they will be leaving medicine in the next 2 years. This is not leaving to retirement. This is leaving for another career. And if we combine that with some previous work, we might estimate that a third of those physicians will carry out their intention. And that means that 1 out of every 200 physicians right now is likely to leave their practice for another career, often because of discouragement over what the current practice is like. And that would be the loss of 5,000 physicians or the loss of the graduating class of 35 medical schools. So I think this is an important issue for us to continue to work on so that patients can get care from physicians and their teams who enjoy their work, and so that patients can have access to care. So I just want to run through a couple of things that we're doing at the AMA. In the past, I've mentioned that we have Steps Forward, which is a series of online free practice transformation toolkits. We currently have 44 such toolkits on how to re-engineer your practice, how to have a team meeting, how to do co-location, how to have team-based care. We have 6 new modules that are coming online in June, including one on diabetes management, one on immunizations for adults, on an embedded pharmacist, on having open notes, which is a form of transparency around notes, how to improve the patient experience, and inbox management. I'm actually really enthused about the inbox management module in particular. Those of you who are EPIC users will appreciate that it was written by Belen up in Green Bay and uses a lot of EPIC language, so I think it'll be very accessible. We're also now able to do some bit of joy or burnout assessments and consultations with organizations. We have worked closely with Mark Linzer, who and his team, who are contracted with us at the AMA to support our work. And so we can go into an organization and survey the clinicians using the Mini-Z. We fielded a 1,000 physician benchmarking survey, so we have comparative data, normative data, and we've done pilots so far, and we can give not only a total score. I've been calling it the Joyful Workplace Survey, although I think we'll go back to calling it the Mini-Z. So we can give you a total score, we can compare it to the benchmark, and we can also compare it to what would be considered an ideal range. And then we can give subscores for a supportive work environment and a second subscore for EHR stress. And then finally, we've been holding a series of Joy in Medicine meetings, and I just wanted to bring you into those meetings a little bit. We hosted a Joy in Medicine Research Summit, and Brian Arndt was able to be there with us. We brought 35 researchers from around the country to talk about what do we know, what do we need to know, and where do we go from here around burnout. And the proceedings from that will be published later this spring in Annals of Internal Medicine. As I mentioned, we brought the CEOs from a number of organizations together, and they have published their blog. We had the International Conference on Physician Health, which was sold out this year. And then next September will be the first American Conference on Physician Health that will be co-sponsored by Stanford, Mayo, and the AMA. It'll be in San Francisco. Those dates are wrong. It's in October. It's October 10th through the 12th. And then we have 2 more meetings coming up later this month. One is for CMOs and COOs so that they can share best practices to reduce burnout and improve joy in work across organizations. And then another is a multi-stakeholder group where we're bringing together patient advocates, providers, policymakers, payers, vendors together. So we have people from CMS, we have people from EPIC and Cerner and Athena, and we have patient advocacy groups, and we're going to say, you know, this is a shared problem, and we all have responsibility for contributing to the problem and for contributing to the solutions to this problem. And the whole goal of that is so that whether you're a new nursing grad, a new medical grad, we can hope that you will land in a place, as I hope that my niece Allie will land, where she can say that joy in work is possible, and where perhaps she can relate to this quote that we'll end with, that comes from Meg Gaines, who is here at UW, who has modified a famous quote from Frederick Buechner. A person's call can be found where the things that give you joy intersect with the needs of the world. And my hope is that the work that happens out of I-PrACTISE, the work that Tom is doing in academic and private practices, and the work that we're doing at the AMA can make it possible for people to land in places where, in fact, the things that give us joy intersect with the needs of our patients. So thank you very much. And I'll be happy to take questions.